Assalamu alaikum. Now, uterine inversion. It's a continuous series of video regarding obstetrics. Start with this uterine inversion. Uterine inversion occurs. Uterine inversion can occur due to excessive. It occurs due to excessive traction. It occurs due to excessive traction of the umbilical cord. It occurs due to excessive traction of the umbilical cord with an adherent placenta causing uterine fibroids causing uterine fundus to invert and prolapse. Although it can cause BPH, patients typically have severe abdominal pain and a smooth protruding and and a smooth protruding and a smooth mass protruding from the cervix or vagina, and no palpable uterine fundus. There is no palpable uterine fundus. Uterine inversion. It occurs due to excessive traction on the umbilical cord, excessive traction of the umbilical cord with an adherent placenta, causing the uterine fundus to invert and prolapse. Although it can cause BPH, patients typically have severe abdominal pain and a smooth mass protruding from the cervix or vagina. There is no palpable uterine fundus. Patients with uterine inversion typically have severe abdominal pain, heavy vaginal bleeding with possible hemorrhagic shock, hypotension, neurogenic shock due to traction effect of the surrounding peritoneum may also occur, resulting in paradoxical bradycardia. Neurogenic shock due to traction of the surrounding peritoneum may occur, resulting in paradoxical bradycardia. Uterine inversion requires discontinuation. These uterine inversion need discontinuation of the uterooxytocin and immediate manual replacement of the uterus to prevent exsanguination. Manual replacement of the uterus to prevent exsanguination. If the placenta is still attached to the uterine wall, it should not be removed until after the uterus is replaced, because the risk of it should not be removed. It should not be removed until after the uterus is replaced, because it can cause massive hemorrhage. Uterine relaxations and laparotomy may be required if initial attempts for manual reduction are unsuccessful. If manual reduction is unsuccessful, then you should do laparotomy. Then vaginal hematoma. It's a cause of postpartum hemorrhage appear that can appear as a firm, rounded vaginal mass that can appear as firm, round vaginal mass. However, blood loss is typically hidden in the paravaginal space. Occult bleeding with no passage of large clots, and the uterine fundus remains palpable. Transabdominal vaginal hematoma, operative vaginal delivery, infant more than 8.8 pound, nulliparity, prolonged second stage of labor. Clinical feature is vaginal mass, rectal or vaginal pressure, with or without hypovolemic shock. Treatment is non-expanding is observation and expanding is embolization. Vaginal hematoma, operative vaginal delivery, infant more than 4 kg, nulliparity, prolonged second stage of labor. Clinical feature is vaginal mass, rectal or vaginal pressure, hypovolemic shock. Non-expanding is observation, expanding is embolization and surgery. During the delivery, stretching of the vaginal canal can injure the uterine artery, particularly in the nulliparous patient undergo operative vaginal delivery. Undergoing operative vaginal delivery, forceps assisted, or delivering an infant more than 4 kg. The resultant injury can cause massive postpartum bleeding as the uterine artery during pregnancy enlarges and supplies the uterus up to 30% of the total cardiac output because the blood collects the paravaginal space. A large potential space causes massive occult bleeding. Can cause massive occult bleeding evidenced by hypovolemic shock initially. However, as the blood continues to collect within the paravaginal tissue, patient can develop protruding vaginal mass associated with rectal or vaginal pressure and minimal vaginal bleeding. What are the secondary or late postpartum hemorrhage? Cause of late postpartum: retain product of conception. It may cause heavy bleeding with or without uterine atony. At that case, DNC should be done. Retain product of conception may cause DNC. Placental site subinvolution can cause uterotronics like oxytocin, methyl argonovin, carboprost. Carboprost should not be given in asthma, and methyl argonovin should not be given in hypertension. And oxytocin can cause hyponatremia. Postpartum endometritis fever, uterine tenderness, and purulent lochia. This for this Clinda and Genta should be given. Fever, uterine tenderness, and purulent lochia. Postpartum endometritis. Three, these three is the secondary late postpartum hemorrhage. Secondary late postpartum hemorrhage. In postpartum endometritis, there is uterine tenderness. Uterine tenderness is present. Okay. Heavy vaginal bleeding means saturating more than 1 pad per hour and passage of large clot more than 24 hours of delivery. More than 1 pad per hour and passage of large clot more than 24 hours. Risk for secondary PPH are similar to immediate onset PPH, include prolonged labor, fetal macrosomia, and intraamniotic infection. In contrast to a written placenta which causes immediate PPH, with uterine atony, a boggy enlarged uterus, written product of conception typically cause late PPH with either a boggy or firm uterus. Evaluation is with pelvic ultrasound. Which can identify the location of the written products, and treatment is typically DNC. Uterine rupture prior uterine surgery. Uterine rupture is prior uterine surgery, induction of labor or prolonged labor, congenital uterine anomalies, and fetal macrosomia. Prior uterine surgery, induction of labor or prolonged labor, congenital uterine anomaly, and fetal macrosomia. Clinical is Vaginal bleeding, clinical presentation, vaginal bleeding, intra-abdominal bleeding may cause hypotension, tachycardia, fetal heart rate deceleration, loss of fetal station, palpable fetal parts on abdominal examination, and loss of intrauterine pressure. Management is laparotomy or delivery and uterine rupture. Uterine rupture prior uterine surgery, induction of labor or prolonged labor, congenital uterine anomalies, and fetal macrosomia. Clinical is vaginal bleeding, intra-abdominal bleeding, fetal heart deceleration, loss of fetal station, palpable fetal parts on abdominal examination, loss of intrauterine pressure. These can short interpregnancy level less than 6 to 18 months for last delivery, and maternal age more than 35 increased risk of uterine rupture. These uterine rupture, there is a high yield increased risk. Short interpregnancy interval less than 6 to 18 months and maternal age more than 35 can cause uterine rupture. Uh, it can cause late PPH in patients with prior cesarean delivery and typically present with severe uterine tenderness and abdominal pain. Severe uterine tenderness and abdominal pain. Uterine rupture usually occurs in patient prior uterine surgery, cesarean delivery, myomectomy because weakened scar can separate the force of the contraction. Patient can develop massive bleeding and due to high vascular pregnant uterus. When the uterus ruptures, maternal fetal compromise occurs by multiple mechanisms. If the placenta involved, fetal perfusion disrupted leading to fetal hypoxia, late deceleration and prolonged bradycardia. If umbilical cord prolapse into the maternal abdomen, cord compression may increase variable deceleration because either or both are likely to occur. An abrupt fetal heart rate tracing abnormality is the most common finding. An abrupt fetal heart rate tracing abnormality is the most common finding of the uterine rupture. Disorder contraction occurs because of rupture myometrial fibers cannot contract in unison. This is often evidence by progressively decreasing contraction amplitude staircase sign on tochodynamic. Decreased contraction occur because of the rupture myometrial fibers cannot contract in unison. These is often evidenced by progressively decreasing contraction. Partial fetal delivery into the maternal abdomen. Partial fetal delivery into the maternal abdomen can cause fetal head retraction, +1 to -2 station, and loss of fetal station. Fetal part may become visible abnormally. This is another reason. And myometrial tearing causes severe abdominal pain and thus causing this hemodynamic abnormality. An abnormal heart rate tracing is often the first sign for uterine rupture and can present with bradycardia, late deceleration, and variable deceleration. Uterine rupture is an obstetric emergency. Requires laparotomy and cesarean delivery for immediate delivery and uterine rupture. This is uterine rupture, fetal heart rate, uterine contraction. After delivery, lochia can continue up to 6 weeks of postpartum. Patients with a weak postpartum typically have lochia rubra. While lochia serous is serosanguinous discharge that soaks less than 1 hour. Amniotic fluid index oligohydramnios and polyhydramnios. Oligohydramnios is single deepest pocket of amniotic fluid is less than 2 centimeters. Single deepest pocket of amniotic fluid. If the single deepest pocket of amniotic fluid is less than 2 centimeters and if amniotic fluid index is less than 5 centimeters, it is oligohydramnios. Polyhydramnios, if amniotic fluid index is more than 24 centimeters, single deepest pocket of amniotic fluid is more than 8 centimeters, it's called polyhydramnios. Oligohydramnios is renal uterine uteroplacental insufficiency, renal uteroplacental insufficiency, a preeclampsia, abruptio placentae, and NSAIDs. This is oligohydramnios. Oligohydramnios, renal uteroplacental insufficiency, preeclampsia, abruptio placentae, and NSAID. This is oligohydramnios. And polyhydramnios is esophageal or duodenal atresia, anencephaly, multiple gestation, congenital infection, and diabetes. Complication for oligohydramnios is meconium aspiration, preterm delivery, and umbilical cord compression. Meconium aspiration, preterm delivery, and umbilical cord compression. This is oligohydramnios. And polyhydramnios, the complications are fetal malposition, umbilical cord prolapse, preterm labor, preterm premature rupture of the membrane. Cause of polyhydramnios is renal uteroplacental insufficiency, preeclampsia, abruptio, placentae, and NSAID. And complication is meconium aspiration, preterm delivery, and umbilical cord compression. Oligohydramnios, early gestation oligohydramnios concerning for fetal etiologies. Second and trimester causes of oligohydramnios typically due to uteroplacental insufficiency. Second and third trimester is uteroplacental insufficiency with concomitant fetal growth restriction and maternal cause such as dehydration or rupture membrane with normal fetal growth. Dehydration and rupture of the membrane cause normal fetal growth. Early gestation oligohydramnios is concerning for fetal etiology, aneuploidy, renal agenesis, posterurethral valves, because amniotic fluid volume is dependent on fetal urine production. At term gestation, the most likely cause of new onset oligohydramnios is spontaneous rupture of the membrane. At term gestation, the most common cause of new onset oligohydramnios is a spontaneous rupture of the membrane. Now, polyhydramnios. In polyhydramnios, fundal height, that is, uterine size, is measured during routine prenatal visits in the second and third trimester as an indirect assessment of fetal growth and amniotic fluid volume. After 20 weeks of gestation, fundal height in centimeters should directly correlate with the gestational age in weeks, with a small variation. Gestational diabetes mellitus causes uterine size greater than dates. Discrepancy by two mechanisms. Uterine size greater than dates. It can cause fetal macrosomia. It can cause polyhydramnios. How these things are going to happen? Excess maternal blood glucose cross the placenta, causing fetal hyperglycemia, increase insulin secretion, insulin-like growth factor production. These promote fetal growth and fat deposition, resulting in fetal macrosomia. So why macrosomia is happening? As just as excess maternal blood glucose can produce excess maternal blood glucose can cross the placenta, causing fetal hyperglycemia, and fetal hyperglycemia may cause produce increased insulin like growth factor, and these promotes fetal growth and fat deposition, resulting in macrosomia. And how polyhydramnios is going to happen? Fetal hyperglycemia also induces osmotic diuresis and polyuria. It induces osmotic diuresis and polyuria, which increases amniotic fluid volume, resulting in polyhydramnios. A uterine size discrepancy requires further evaluation with an ultrasound to measure fetal growth and amniotic fluid volume. Although some patients with polyhydramnios and identifiable cause diabetes mellitus fetal tracheoesophageal fistula, most are idiopathic. Patient may have abnormal discomfort from increased uterine size, dyspnea due to maternal lung compression, from preterm contraction from increased intrauterine pressure. However, most patients are asymptomatic. Management is based on severity, maternal symptom, and gestational age. Patients with severe and symptomatic polyhydramnios at preterm gestation are at increased risk of obstetric complications, include preterm labor, pre-labor rupture of the membrane. Therefore, these patients may benefit from amnio reduction, amniotic fluid removal by amniocentesis. In contrast, patients with mild asymptomatic polyhydramnios at term gestation can undergo expected management because obstetric outcomes are unchanged by increased antenatal fetal surveillance and intervention. Now twins, very, very, very high. Monochorionic, monoamnionic, monoamnionic. Monochorionic means one placenta. Monoamnionic means one one placenta, one amniotic sac. This is monochorionic, monoamnionic. Dichorionic, diamnionic means two placenta, two amniotic sac. Monochorionic, diamniotic. This is monochorionic, diamniotic. That means one one placenta but two amniotic sac. And dichorionic means dichorionic diamniotic means two placenta and two amniotic sac. So monochorionic, monoamniotic, one placenta, one amniotic sac, monochorionic MD, monochorionic diamniotic MD, monochorionic diamniotic is a T sign, monochorionic is a T sign, T sign. Monochorionic diamniotic is a T sign, and dichorionic diamniotic is D DL, lambda sign. So MD is a trophy, and DDL, dichorionic diamniotic, is lambda sign. In here, in twin pregnancy, maternal complication is hyperemesis gravidarum, hyperemesis gravidarum, preeclampsia, gestational diabetes mellitus, IDA, and fetal is congenital anomaly. Fetal growth restriction can happen. Preterm delivery can happen. Twin transfusion syndrome and monochorionic twins can happen. Twin and monoamniotic twins. Monochorionic twins can happen. Twin transfusion and monoamniotic twin can have conjoined twin. Monoamniotic twin have conjoined twin and cord entanglement. Twin pregnancies are increased risk of a preterm delivery, very high. Twin pregnancy less than 37 weeks is due to spontaneous preterm labor and medically indicated delivery secondary to maternal preeclampsia and fetal growth restriction complication. Fetal growth restriction. The increased risk of spontaneous preterm labor is likely the result of uterine crowding, multiple gestation, and uterine overdistension, uterine size and dates discrepancy. Uterine overdistension causes overstretching of the myometrium, which results in increase in prostaglandin production, number of oxytocin receptor, and contractility within the uterus. Dichorionic diamniotic pregnancy have two placenta, two amniotic sac. However, due to fetal overcrowding, some dichorionic diamniotic twins develop an obscured intertwin membrane that causes the separate placenta to have a single fused appearance on ultrasound. However, dichorionic diamniotic gestations with a fused placenta can be identified by a thick intertwin membrane and a placental projection when intertwin membrane meets the placenta, lambda sign. Monochorionic monoamniotic twin pregnancies are at risk of cord entanglement and fetal demise. Therefore, monochorionic monoamniotic twins managed inpatient beginning at 28 weeks of gestation. Patient delivered preterm 32 to 34 weeks via cesarean delivery. This is cis and monochorionic monoamniotic. Dichorionic diamniotic. Monochorionic diamnionitic is MD. Monochorionic diamnionitic that is the trough, and diachronic diamnionitic is lambda sun lambda. Monochorionic twins have increased risk of twin-twin transfusion syndrome. Twin-twin transfusion syndrome, a complication can result in a complication can result in heart failure, neonatal mortality in both twins. In twin-twin transfusion, unbalanced heavy anastomosis are present between the shared placental vessels that supply the twins. The shunting of the blood away from the donor twin causes anemia that leads to renal failure, oligohydramnios, low output heart failure, fetal growth restriction. In contrast, the shunting of blood toward the recipient twin causes polycythemia, which can lead to polyhydramnios, cardiomegaly, high output cardiac failure, hydrops fetalis. Both twins are at risk for intrauterine and neonatal death. Mild twin-twin transfusion syndrome is managed serial ultrasound to evaluate worsening clinical fetus. Twin-twin transfusion syndrome, arteriovenous. This is lambda sign. Fetus 1, fetus 2. This is lambda sign. Heterotrophic pregnancy is the presence of both intrauterine and ectopic pregnancy. Fetal dysmaturity syndrome occurs post-term, more than 42 weeks of gestation pregnancy, due to uteroplacental insufficiency. Now, hyperemesis gravidarum. In hyperemesis gravidarum, there may be identity for multiple gestation and history of hyperemesis gravidarum. Hyperemesis gravidarum, prior hyperemesis gravidarum, identity for mole and multiple gestation. Severe persistent vomiting, more than 5% loss of pre-pregnancy weight, dehydration, orthostatic hypotension, lab is ketonuria, hypokalemic, metabolic alkalosis, hypokalemia, and hemoconcentration. Admit to the hospital, antiemetics, and IV fluid. Hyperemesis gravidarum is unresponsive to oral antiemetic, can be differentiated from typical nausea vomiting by the presence of ketone in urine. If there is urine for ketone is present, then it is hyperemesis gravidarum. Severe hyperemesis gravidarum uh, can cause dehydration, ketonuria, lab abnormalities in an indication for hospital admission for IV intravenous antiemetic, rehydration, and electrolyte repletion. Twin gestation are thought to be an increased risk of hyperemesis gravidarum due to elevated beta hCG and progesterone concentration from a large placental volume. hCG levels which peak at the same time as hyperemesis gravidarum symptom may be a cause of increased nausea. May cause a transient hyperthyroidism because of elevated hCG, share a similar subunit of TSH, and therefore can have thyroid stimulator hormone activity. Frequently resolves within 16 to 20 weeks of gestation but can persist until delivery. Tobacco use protects against hyperemesis gravidarum likely because it increases metabolism of estrogen and thereby decreases serum estrogen level. Post-term, late and post-term. Late term more than 41 weeks of gestation and post-term is more than 42 or more than 2. Late is Risa and post is Nisha. Risk factor prior post-term pregnancy, nulliparity, obesity, age more than 35, and fetal anomalies and anencephaly. Prior post-term pregnancy, nulliparity, obesity, age 35 or more, fetal anomalies. Fetal or neonatal macrosomia, dysmaturity syndrome, oligohydramnios, demise, MOD, macrosomia, dysmaturity syndrome, oligohydramnios, and demise. What is dysmaturity? Fetal dysmaturity syndrome. It occurs in post-term pregnancies due to age-related placental change and result. It causes uterine placental insufficiency. Neonates are small for gestational age, have a thin body, loose skin, and have a meconium stained amniotic fluid. It can cause late and postpartum pregnancy can cause oligohydramnios. Why oligohydramnios? Because babies um, getting bigger and bigger day by day. The amount of fluid is will be reduced because there is no space here. Maternal severe obstetric laceration, cesarean, PPH. Management is frequent fetal monitoring, non-stressed delivery prior to 43 weeks of gestation. Progressive placental dysfunction can lead to uteroplacental insufficiency and chronic hypoxemia. Signs of uteroplacental insufficiency include late dissolution, non-stress tests, and oligohydramnios. Single deepest focus less than oligohydramnios occurs due to uteroplacental insufficiency because fetal blood is shunted from the kidney. Fetal blood is shunted from the kidney, which produces amniotic fluid to the brain to prevent central nervous system suppression from the chronic to, to the brain to prevent central nervous system suppression from fetal hypoxemia. So oligohydramnia due to uteroplasm because fetal blood is shunted from the kidney produce which produce amniotic fluid to the brain prevent central nervous system suppression from chronic hypoxemia. Late deceleration oligohydramnios patient with suggestive uteroplasm defibrillation oligohydramnios required immediate delivery for prevent intrauterine demise. Short interpregnancy interval. Short interpregnancy interval. Short interpregnancy interval. Less than 6 to 18 months delivery to next pregnancy. Maternal anemia. Preterm delivery. Low birth weight. Preterm delivery. Preterm pre-labor rupture of the membrane. Short interpregnancy interval less than 6 to 18 months. And that's all. This is the other system regarding obstetric. So I have completed the obstetric. Uh, some topics are remain. So hope you enjoyed.